Intermittent pneumatic foot and calf compression is widely accepted for circulation improvement in patients with lower extremity arterial disease, venous ulcers, ischemic limbs, and claudication. We will explore how it actually exerts its beneficial effects on the lower extremities and the subsequent biochemical changes in circulation and striking physiological structure hemodynamic changes in the lower leg. Studies have shown that a 120 millimeters of mercury sequentially wave-like application of pneumatic compression provides the most efficient method of venous emptying in subcutaneous tissue and muscle groups, leading to decreased surface tension, improved transcutaneous oxygenation, and clearance of metabolic toxins. Studies show 98% of patients increased claudication distance by over 100%, increased resting ABI by 18%, post-exercise ABI by 110%, increased arterial calf flow by 36% within 4.5 months. In the deep veins, there is a slow, steady flow of blood within its lumen prior to compression. When compression is applied, this sudden pressure gradient at the pressure zone accelerates the blood forward with a subsequent collapse of the lumen at the compression zone, effectively facilitating venous emptying and preventing stasis. The accelerated blood moves forward and causes distension of the compliant lumen. The distension exerts up to 48% strain on the endothelial cells. The mechanical forces of strain and shear continues to cause a physiological response in the endothelial cells, triggering release of biochemical mediators, TPA, tissue plasminogen activator, NO, nitric oxide, and prostacyclin. Both NO and prostacyclin are smooth muscle inhibitors causing vasodilation and have been proven to increase red blood cell deformity to facilitate blood flow in vasculature with high resistance. Distension caused by the rush of blood demonstrates improved emptying of lower extremity veins, causing lowered venous pressure, which is translated to the arterial system. The sudden decrease in venous pressure causes an increase in AV disparity, leading to an increased arterial flow velocity. During compression, heat flow calorimetry and plethysmography has reported an increased popliteal artery flow of 93%. The increase in the AV pressure gradient and subsequent increase in arterial flow is mechanism for improving patients with claudication. During compression treatment, the physiological mechanism showed an increase in cutaneous tissue oxygenation, removal of CO2, decreased interstitial fluid volume, lowered venous pressure, and decreased venous stasis, all leading to increased blood flow to the foot. Treatment of venous ulcers secondary to venous insufficiency showed an increase in healing ulcers by 17.7% area per week.